Welcome everyone to our April Teach Educational Rounds. Here with us today, we have Dr. Khara and Sophia Konstantakis, who will be presenting on pharmacological quit aids, methods, myths, and treatment plans. So we'll get started with CAMH's land acknowledgement. CAMH is situated on lands that have been occupied by First Nations for millennia, lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase Treaty No. 13 of 1805 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. CAMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. Now, I invite everyone to introduce themselves in the chat and let us know which traditional territory they're joining us from today. If you're not sure, you can find out at that website there. I'll put the link in the chat for anyone who needs it. And you're also encouraged to let us know something you're doing to learn or improve your commitment to reconciliation. I'll give everyone a few moments to do so. In the meantime, if it's your first time joining, my name is Natalie, and I'll just share a bit about myself. So I'm, like CAMH, currently located on the lands of the Mississaugas of the Credit as well. And as a white settler, I acknowledge the privilege I have and am extremely grateful to work in the Intrepid Lab at CAMH, where we really ensure reconciliation is intertwined within all the work that we do. So I'll give everyone a moment to share in the chat. Thanks, Tracy. Welcome. Oh, awesome. Yeah, that was a great training. I also completed that training recently. I'll give everyone a few more moments. Welcome, Jamil. Awesome. Thanks, everyone. In the meantime, I'll keep going with some housekeeping items, but please do keep sharing in the chat. We would love to read your comments. So if you're interested in receiving a letter of completion for this Teach Educational Rounds, please make sure you've registered for the webinar and completed the pre-learning assessment. As well, make sure you signed in using your full first name and last name so we can track your participation. And last but not least, please make sure to complete the evaluation and post-learning assessment. That will be emailed to you by tomorrow, and you'll have 1 week to complete that. Along with that, you'll also receive these slides and recording to refer back to or share with any colleagues. So here's a little bit more information about our presenters today. Sophia Konstantakis is a registered nurse here in Ontario and has been working at CAMH since 2005, where she's witnessed and adapted to the ever-changing smoking-related policies at the hospital and across the province. She's worked in various other areas in the hospital over the years, including the mood and anxiety inpatient unit. And she currently works in Intrepid Lab, where she's been able to further develop her knowledge and skills in smoking cessation. So welcome, Sophia. And no disclosures for her to report. And next up, we have Dr. Milan, who has been working at Vancouver Coastal Health since 2003, having previously worked as an addiction medicine consultant at CAMH in Toronto. Certified by the American Society of Addiction Medicine, his current work primarily focuses on treating tobacco use disorder, but also extends into other areas of tobacco control. His research interest specifically focuses on hard to treat populations and has been published in medical journals. So welcome, Dr. Khara, and no disclosures to report on his end either. So please note that the content of Teach Educational Rounds is centered on evidence-based guidelines from the following sources. Nonetheless, these materials, as well as the verbal presentation and any discussion, represent only general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare professionals. So please feel free to use the chat feature throughout the webinar to post any comments or answer any prompts from the presenters. To do this, you can click on the speech bubble icon in the control panel. And please ensure you select everyone so that all hosts, attendees, and panelists can read and respond to your comments. You're also very welcome to send a reaction if you want to send a smiley face or anything throughout the webinar. Please feel free to do so. In the meantime, I will hand it off to our presenters to take it away. Thank you, everyone, and enjoy the webinar.
Thank you so much, Natalie. Hi, everyone. I'm Sophia. I'm also joining from Mississaugas of the Credit. Thank you all for joining us this hour. I know for some of you it's breakfast, for us it's lunch. Some people are maybe wrapping up at work. So we really appreciate you joining us today for our Teach Educational Rounds. Our topic today is pharmacological quit aids, methods, myths, and treatment plans. Dr. Khara is going to be starting us off today, so please, I'll hand it over to you.
Thanks, Sophia. Thanks, Natalie. I hope everyone can hear me. I'm presenting from Vancouver, from the unceded territories of the Coast Salish people. I'm grateful to be able to live and work on these lands. So we'll get right into it because time is tight, but you see the title there. I will flip slides and get to our learning objectives. So we're going to talk about cessation medications today. Important to make the point that when we help people quit smoking or make any behavior change, it's never just about the meds. Behavioral counseling, we know, increases the likelihood of effective cessation, and is arguably just as effective as the patches or the pills. And the combination of the two is going to give us the best return. So though we're not going to talk about behavioral counseling today specifically, that's just to make the point that this is about the meds and the NRT and so on and so forth. So not neglecting behavioral counseling, but that's not what today's about. So we're going to talk about the mechanisms of action of these medications, the relative advantages and disadvantages of one product versus the other. That will be a real fly through. There's a lot of detail in these slides. It's not the best use of our time for me to focus in on those details, but we'll try and leave the most time to talk about misconceptions, things that get in the way of patients using these products in the best way possible, things that get in the way of healthcare providers actually providing accurate information. And then we'll try and apply some of those thoughts, some of those concepts to at least one case. So that's kind of roughly what we're going to cover. If you talk to us in the chat as we go, and you want to tell us that we're not talking about the things that you want us to talk about, then we will pivot and try and deal with those things. So please try and keep this as interactive as possible, because I think that will provide the best value session. Okay, so most of you are familiar with this construct, the 5 A's of brief intervention. But if you're not, what we talk about when we describe the 5 A's is this consistent way to do tobacco intervention, whatever healthcare setting that you're in, that takes a couple of minutes, and that is actually evidence-based. We know that if we do this, we increase the likelihood of cessation by somewhere between 30 and 50%, depending on what data you look at. And it's the ask about tobacco use, advise all tobacco users that they should quit using cigarettes if they can, assess their readiness to quit, and if they are in fact somewhat ready to quit, we move on to assist. And it's in the assist part that we're going to start to talk about medications. So that's really what we're focusing on today. And why are medications important? Well, this is a nice old study from a psychiatrist in the United States by the name of John Hughes. And if you look at the graph on the left, the vertical axis shows the percentage of those abstinent, and the horizontal axis shows time quit. And what those curves represent are relapse curves. So in people doing unassisted cessation at day 0, everybody is abstinent because that's the beginning of the quit attempt. So we expect everyone to be abstinent at day 0. But if you look at the way that most of those curves fall off, if you look at day 8, day 10, not marked on the horizontal axis, but just approximate where day 8 or day 10 is, you will see that the majority of individuals have already relapsed. So approximately 80% of people who do unassisted cessation will have relapsed by day 8, day 10. And by unassisted cessation, we mean without the benefit of a patch or a pill. And why is that the case? The reason this happens is that withdrawal for many tobacco users is a pretty unpleasant experience. It involves a whole variety of symptoms, mood changes, irritability, agitation. But first and foremost, it includes craving, and craving leads to relapse for the vast majority of those who do unassisted cessation. And that's why when we can use medications to eliminate or minimize some of those symptoms, particularly the craving, we increase the likelihood of cessation. And we know that most of these medications will increase the likelihood of cessation at 6 months by a factor of 2 or maybe even 3. And here you see the three main classes: the NRTs, Bupropion and Varenicline, the two oral medications that are considered first-line smoking cessation medications in Canada. And more recently, you will have heard some interest in Cytisine, which is now in recent years available in Canada with certain constraints that we'll talk about in a few moments. So those are our available options. NRT, I think all of you know how NRT works. It's the replacement of nicotine from a cigarette, which comes with smoke and thousands of harmful chemicals, with just nicotine through the skin or the buccal mucosa, essentially. The short-acting NRTs all work through the mouth, the gum, the lozenge, the oral mist, and the patch, of course, works through the skin. So that is nicotine, just nicotine, through the venous system, which means that it gets to the brain relatively slowly compared to cigarettes, which deliver nicotine through the arterial system, through the massive pulmonary vasculature. And because it's the arterial system, get into the brain super fast, 7 to 10 seconds. And we can use these NRTs actually for almost any length of time. Though they're recommended for 8 to 12 weeks by the label, we can tailor treatment and use them for almost any length of time. They really come with little or no risk. We know that there's 3 sizes of patch. There's the step 1, 21 milligrams, a step 2, 14 milligrams, a step 3, 7 milligrams. And the classic approach to treatment is the step down approach. So we do 4 weeks of 21, 4 weeks of 14, 4 weeks of 7 milligrams. Now, in reality, we often don't dose in that way, because what we prefer to do today is we prefer to tailor treatment to need. And without spending too long on this just now, it's really much better to step down on dose based on how somebody is doing. Is the patient abstinent? Is there still craving? What happens if you forget to put your dose on? If that's a terrible day where you're craving like crazy and highly vulnerable to relapse, that's probably not the time to step down on dose, even though it says 4 weeks on the calendar. So just really starting to think about moving away from the on-label recommendations to do this in the 4 week approach to individualizing need is really something that I'd encourage everyone to think about. You can see the doses there for the short-acting NRTs. Safe to say that these can be used either with a scheduled approach, so using every couple of hours to try and get ahead of potential craving, or using as an as-required product. So for those who want to use when craving begins, that's fine, but I always encourage our patients to use them as early as possible. Waiting for the craving to take hold is already a bit too late to use a short-acting NRT. And as you can see in that box on the right, those numbers are essentially odds ratios for cessation at 6 months. And you can see all the NRTs have numbers that are somewhere between 1.5 and 2. And what that means is that when we use these products, we increase the likelihood of cessation by a factor of 1.5 to around 2 compared to using placebo in trials. So these things work reasonably well. Combining NRT is now something that is much more commonplace. There is good evidence that when you use a patch plus gum or a patch plus lozenge, you increase the efficacy of your treatment. Again, maybe by somewhere between 15 and 35%. And think of the analogy of pain management. We like to use these long-acting patches or long-acting morphines. with a breakthrough product as well. And think of combination NRT as being exactly that. The patch is on, giving background NRT, reducing craving, but a pocket full of gum or a pocket full of lozenge for the patient who is walking along and suddenly hits a craving for whatever reason, a person, a place, or a thing that drives a craving, and now there's something to do, to reach into the pocket, to take a short-acting NRT, get a bolus of nicotine, and this approach is now considered safe and is increasingly on the label versus the off-label approach that we were doing for many years with combination NRT. Not really many side effects to talk about. I'll just mention two or three things. We know that with the patch, sleep disturbance certainly can be problematic. Most patients will become tolerant to that. And if they can't push through for a few days until they become tolerant, then we can take the patch off at night. Not ideal, because the patient then wakes up in the morning with craving to smoke cigarettes. But ideally, we leave them on for 24 hours unless the sleep disturbance is problematic. And then some skin reaction, about 3 in 10 patients, redness, itching. If it's not particularly problematic, we don't really need to worry too much about it. If it does become problematic, we can use cortisone creams. And the key to avoiding that skin reaction is a lot of rotation. And the patch can actually be put anywhere. It does not need to be limited to above the belt. As per the label, it can be put anywhere that it sticks. It can be on the thigh, it can be on even the calf. It's okay as long as that area is not too hairy and the patch actually sticks. And then the short-acting NRTs, most of the side effects basically pertain to incorrect use. So if you can get those who use the gum to do chew and park rather than swallowing, then they'll avoid the common side effects of hiccups and indigestion. And you can use NRT in almost any situation. Again, even though the label will point out warnings about cardiovascular disease or pregnancy, it's always preferable to use NRT versus having the patient walking out of the coronary care unit to go and smoke cigarettes. Always preferable. It's just nicotine. It doesn't come with smoke and carbon monoxide and the many thousands of other chemicals. So we can use them in cardiovascular disease. We can even use them in pregnancy if behavioral counseling alone is not effective. We may use short-acting NRT to reduce the exposure of the fetus to nicotine, but certainly you can use these products in almost any population, even though there may be some warnings on the label. So I won't say too much more about NRT, mainly in the interest of time. We'll talk now about the 2 oral smoking cessation medications. Of course, we have Bupropion, known as Zyban in its smoking cessation guise, known as Wellbutrin in its antidepressant guise. It's the same drug. It doesn't contain nicotine. It's an SNRI, so that's a selective norepinephrine reuptake inhibitor. It also inhibits the reuptake of dopamine. And we know that a depletion in dopamine is one of the things that drives withdrawal and craving. So if you can raise dopamine tone in the brain, then it would make sense that Bupropion should reduce withdrawal and craving, and thereby be an effective smoking cessation medication, which it is. Approximately as efficacious as NRT, doubles the likelihood of cessation. Some studies suggesting that it minimizes weight gain, so it might be particularly appropriate in somebody who's quitting smoking, who's worried about weight gain in particular. Can be used for really any length of time, but typically used for up to 1 year. 150 milligrams BID is the standard dose when doing smoking cessation of the Bupropion SR. As I said, approximately doubles the likelihood of cessation compared to using placebo. The quit date question is a really interesting one. There are, with all the smoking cessation medications, on-label descriptions of when one should quit. For Bupropion, it's recommended that quitting happens between day 7 and day 14. These are just guides. It doesn't really matter if smoking reduction is happening and smoking cessation doesn't happen till much later. If the medication is reducing craving, reducing consumption, then it's working. The quit date does not have to be in the window that is described on the label. It can really come at any time, as long as there's a sense of progress by the patient who is using it. And that applies to all of the products, in fact. Most of the side effects of Bupropion relate to the fact that it's a stimulating antidepressant. So you will have some patients who will describe anxiety, sleep disturbance. They can be problematic, and for many patients, they're a deal breaker. And when you in fact ask patients about their previous experiences with bupropion, either in the antidepressant version or the smoking cessation version, many will say they didn't like how it made them feel. And that's that agitating, stimulating side effect of the drug. And also, of course, seizure is a side effect, an uncommon side effect, but we tend to avoid the use of the drug in anybody who has a lowered seizure threshold for whatever reason, either a past history of epilepsy, or an eating disorder, or any of the things that we know lower seizure threshold. Okay, I'm going to skip on. Want to say a few things about Varenicline before we run out of time. Of course, Varenicline is the most efficacious of our oral smoking cessation products, known as Champix, is its trade name in Canada. It works as an alpha-4 beta-2 nicotinic acetylcholine receptor partial agonist. What that means is that where nicotine binds in the brain from the cigarette, the Varenicline molecule works in the same receptor. And it does two things in that receptor. It partly turns it on so that it reduces withdrawal and craving, but it also has an antagonist effect so that it blocks the effects of nicotine. So the patient who is on Varenicline, who smokes a cigarette, will often describe either not feeling very much or not liking the feeling of smoking. And that's how we think it works, by this dual action at that receptor. It has the highest quit rates of any of the products that we have, approximately trebling quit rates in most studies. Duration recommended is it's 12 weeks, in fact up to 24 weeks, but again can be used for frankly any length of time in patients for whom it is appearing to work well. The standard dosing schedule: 0.5 milligrams once daily for 3 days, then 0.5 milligrams BID for 4 days, and then 1 milligram BID is the maintenance dose. The reason we do that build-up in dose, in fact, is actually for the patient to become tolerant to the most important side effect, or the most common side effect, which is nausea. If patients do become nauseous, and the nausea is persistent and problematic, we recommend two things. One is to take the pill with a full glass of water or on a full stomach, or in worst case scenario, half dose. Main thing to think about with Varenicline, Natalie, I'm over time, right? You can nod if I am. The main thing we'll just deal with is the issue of suicidality and mood change. This was a thing that came along early in the story with Varenicline, put a lot of people off using it. Many people believe they're not able to use it because of their comorbid mental illness. This issue was largely dealt with by the EAGLE study. So if you want to go and look at more about Varenicline and neuropsychiatric adverse effects, you look at the EAGLE study. And the EAGLE study demonstrated that when Varenicline is compared with patch and bupropion and placebo, there is no increase in neuropsychiatric adverse events, either in those without mental illness and those with stable mental illness. So this drug is really not contraindicated in any population as such. We can talk about that more in the cases maybe, but other than mentioning just that Cytisine is now available to us, I'm going to wrap up. What will I say about Cytisine? Very similar to Varenicline. The Varenicline molecule was based on Cytisine in a lab. This has been used for a long time in Eastern Europe, available now as a natural health product. The main obstacle to its use is the complex dosing regimen, up to 5 times a day. But for patients who want to use something natural, you'll hear that comment from patients occasionally. They can buy this product in health food stores. They can buy it in some compounding pharmacies, but it does appear to be efficacious. Good evidence to suggest that it's about as effective as some of our other first-line products. So I'm going to stop there because I've gone over time. We'll go to myths and facts. Sophia, I think it's you from here.
That was really impressive. You really got through a lot in that short amount of time with the different medications. It was a great description, and lots of people are clapping, so they agree. And we'll hopefully now be able to talk, have more of the questions answered that you weren't able to talk about as we're going through. So we have prepared some myths and facts, and we're going to ask everyone to please participate as we go through them. If you're thinking it's a fact, you can use your thumbs up. You're thinking it's a myth, use your thumbs down. And also please write comments in the comment section. Dr. Khara is going to be reviewing the comment section and we'll bring that into our discussion. There was already one in there. Maybe I could just ask it quickly now to everybody and see what people think. So someone in the comments section asked, can NRT be used for 20 years? I don't know if I know the answer. So maybe people can tell me. So lots of people are saying yes, that NRT can be used for 20 years. Dr. Khara, can you answer that for us?
Yeah, I can. So here's the answer. There is no study that has looked at 20 years of NRT. There is one study that's looked at up to 5 years of nicotine gum use with no downside demonstrated. But the thing to remember here is that when we compare the effects of cigarettes with NRT, there is just no comparison. Cigarettes are highly lethal. NRT carries little to no risk. And the reason I qualify it as little to no risk is because we don't have a 20-year study. But if the use of NRT is stopping a return to smoking, it is always preferable.
Yeah, that makes sense. Thank you. That was one on the fly, so I appreciate that. So we'll go to our first one. You can wear more than one nicotine patch or place it on your chest. So what are people thinking for that? A lot of people thinking that's a fact. And I don't think we have too many comments on that yet. So we're all right. It is a fact. Individuals who are highly dependent on nicotine can use more than one patch. It can be worn anywhere. It's often recommended to wear it above the waist. You want to be finding a spot that's clean, dry, relatively hairless. We also recommend, the reason why it's important to know that you can wear it different places. It doesn't only have to be on your shoulders. You can, in fact, wear it on your chest or your back, because for some people, they fall off a lot, so you can try a different spot, or if it's quite irritating, so switching spots is recommended. Any more comments on that one? No. Okay. NRT is addictive. What do people think about that? Some mixed reviews. So what, Dr. Khara, is anybody putting anything in the comments for this one?
Not seeing anything on this particular issue, so it looks good. I think everyone gets it that NRT carries much lower addiction potential than cigarettes, of course, and by and large is not something to worry about. Just a quick aside, many of you will have heard of the patient who says, I've been using nicotine gum for X years, and they're often worried about that. And clearly these products do have some addiction potential, but of course for the vast majority of people, they have no real difficulty getting off NRT. But for those who say they've been using gum for years and years and years, similar to the previous point about the 20 years of NRT, the answer really should be, if you can come off the nicotine gum, then you should, because it's a ball and chain and you're paying for the use of this product, and it may be something you don't want to do, but and maybe replace it with regular gum and taper off. That would be the ideal thing to do. But if it is preventing a return to cigarettes, just go ahead.
I'm thinking we're not pressuring. People will maybe come off it at their pace. It's not a high pressure to come off of it. You don't have to worry too much about being addicted to it, because it's a safer way to be getting your nicotine. And part of the addiction part, which is how quick, like you had spoken earlier about how when you smoke cigarettes, it gets to your brain, or it gets, into your system in like 7 seconds. Whereas when you're using NRT, it's much slower in terms of how it gets in there. So it's less addictive, much less addictive, safer and less addictive. Okay, next one. Smoking while on NRT can result in a heart attack. Most people are thinking that's a myth. And you're right, it's a myth. There's no evidence to support this myth. If a person is smoking while using NRT, this usually tells us that they're not receiving enough nicotine to maintain their cravings or withdrawal. So that might mean we need to up their patch, for example, the dose. Okay, you cannot take bupropion if you have mental illness. What do people think? Lots of no's. Do people hear this one a lot from clients? I've had a lot of clients tell me that they can't take the bupropion. So it is a myth, according to the Eagle study. There's no significant increase in neuropsychiatric adverse events as a result of bupropion relative to nicotine patch or placebo. People can still, for sure, you might want to discuss with the prescribing physician or psychiatrist, depending on other medications they might be on. For bipolar disorder, it is people are generally well protected if they're also on a mood stabilizer, and there aren't contraindications to those using SSRIs, but for sure, you'd want to discuss with the prescriber, whoever's treating the mental illness that the client is on, what other medications they're on, and so forth. Anything to add to that, Dr. Khara? Or any comments in this section?
Yes, Sophia, thanks for that comment, because that was one of the questions. So just to reiterate that, you can use Zyban whilst taking an SSRI. That is not contraindicated. There is a theoretical risk of adding bupropion to an MAOI, which is an old class of antidepressant that is by and large not really seen in practice anymore. But with the SSRIs, it's usually going to be just fine. Can I just pull up one of the comments as well that I've seen on the chat? Some myths about tattoos and placing a patch over it. I don't know if you've heard that one, Sophia, but there's no real reason why you can't put a patch over a tattoo. No real reason why you can't do that.
Mm-hmm. The other one, sorry,
I've had patients.
Go on.
Sorry. I've had patients who didn't want to have a tarnish in their suntan, so I had them wear their patch on their foot. Slightly humorous, but makes a good point, which is that you can put the patch anywhere. It's absorbed by the venous circulation. It's all going to go back to the vena cava, which is the big vein that goes into the heart. So whether you put it right over the heart or on the foot, it's taking the same route, so it can go anywhere.
And the other one about the patch, because I know we're moving on to different medications now, was about cutting it in half. I don't know if someone asked about that in the comments as well. Can you speak to that a little bit?
Yeah. So great question. And everyone who looks after people who are trying to quit smoking must have had patients say, I cut the patch in half, is that okay? And the technically correct answer for it is that it's actually not ideal, because when you cut the patch in half, you damage the time release mechanism. So this is the answer that comes from the manufacturer of the patch. I have to say I'm not convinced by that, because I've never heard anybody have an adverse effect from cutting the patch in half. But what I actually recommend is that you can get the same effect as cutting the patch in half by only applying half of the patch by removing half of the backing.
Oh.
So the backing is in two halves. You remove half the backing on day one and apply the patch. And then on the second day, you remove the rest of the backing and press it firmly down. That should effectively be half of the patch each day. So that's what I recommend. But I'm not convinced that cutting the patch in half does any great harm. What's your comments on it, Sophia? Do you obviously hear the question as well?
I actually wasn't sure, because my understanding of it was that it was absorbed like that. The way that it is absorbed has to do with the size of it. Like it's kind of the same amount per, square, whatever, like millimeter or whatever. So I understood that cutting in half shouldn't make a difference, and that it should be absorbed. The other thing I was curious about is, like, if it falls off and you put it back on, like, is it absorbed at the same rate throughout? Like, when you put it on, is there a peak in the day, like in hours when it absorbs, or does it absorb kind of?
Yeah.
So
Well,
I was always wondering about that.
Yeah, it does absorb evenly over time. It takes a few hours to reach a peak, but it certainly does absorb evenly over time. And if it falls off, the right thing to do is to just put it back on again.
Yeah.
Can I just answer one of the questions from the chat here? This is a great question. Why is NRT spray faster than the other forms of short-acting NRT? It's a really good question, and to be honest, I think that's oversold by the manufacturers, that it's the fastest onset of action. The only difference is that the nicotine spray is landed onto the buccal mucosa more quickly than extracting it from lozenge or gum. But once it gets to the buccal mucosa, the absorption is going to be the same. So it may be technically faster, but I don't think that should be like a big selling feature for your patients that, hey, use the spray. It's, it's super fast. It's the best option. I think it should just be one of the short-acting options. And a lot of people, in fact, don't like the spray because it has a very intense, peppery, tingly kind of taste. But it's a legitimate option.
I'm going to get to Varenicline because I see a question in the comments about Varenicline as well. So this one we did cover about Varenicline, can it lead to suicide? And I think I don't know if people think this is a myth or a fact, but I think a lot of people are saying it's a myth, which you have covered. But also in the comments section, someone's asking about the dosing with Varenicline. Do you see that question?
Right. I think the dosing question was about how to dose reduce. And yes, you would go from 1 milligram BID, which is the standard maintenance dose, to 0.5 milligram BID, because you want to get that 24-hour coverage. So you don't really want to go to a once daily dose. You still want to keep it BID. And in some of the pre-registration trials, there's not a lot of fall off in efficacy by going to a half dose. So you maintain most of the efficacy at half dose. So that's certainly a good step to take, mainly to combat the nausea side effect. This is a great question as well.
Yeah. So what do people think? Can you be on Varenicline and NRT at the same time? So
before you bring up the answer, Sophia,
yeah,
somebody in the chat box made a very, very good comment, which is it doesn't, words to the effect of, it doesn't seem logical because Varenicline is blocking the nicotine receptor. So why would we recommend somebody use gum,
right.
with nicotine gum with Varenicline? That's the correct question to ask.
Yeah.
The way well, first of all, there is some evidence now that Varenicline plus patch is more effective than either product alone, and there doesn't seem to be an increase in adverse effects, which might be a little surprising based on that blocking of the receptor concept. But the way I look at it is that presumably the blocking of the receptor is not absolute. And so you take Varenicline, you get some switching on of the receptor, you get some blocking of the receptor. But for those who are continuing to smoke, presumably you can still get some added benefit by getting nicotine replacement therapy to get through some of that blockade and do some more turning on of the receptor. And this is just kind of educated conceptualizing, right? I mean, we don't know exactly what's going on, but certainly my clinical observation is that people who use Champix, who reduce a lot, can do quite well with an addition of some nicotine gum. Now, whether that's a behavioral effect of delay, distract, do something with your hands, or whether it's a pharmacological effect, again, difficult to separate. But I think for somebody who uses Champix or uses Varenicline, reduces a lot, and is looking for more pharmacological help, it's logical to say, here, take some gum and try that as well.
Yeah, thank you for explaining. The other piece to it, does it matter the timing? Because there was something similar, I don't know, correct me if I'm wrong on this, but similar to like like side effects almost related to like precipitated withdrawal. Like for example, if you had the patch on and then you were to take Varenicline, are you more likely to feel sick because it's like maybe replacing all the nicotine that you had very quickly, like, and you'll have extra withdrawal symptoms? Is that accurate or no?
Yeah, yeah, I'm not convinced that that's a thing. I haven't seen it, and yeah, I wouldn't spend too much time being concerned about that. If someone has a particular experience of seeing that, I'd be very interested to hear about it. But I haven't seen it, and I understand where it comes from. We're obviously thinking about Suboxone, and we're thinking about the opioid world, where precipitated withdrawal is a very real thing and a very unpleasant thing. And I have seen that. I've caused it. But I don't think it's a thing with Varenicline and NRT.
Okay. So it's okay to use a little bit on top, and it does help. It's okay to use an NRT on top of Varenicline, and a lot of people find it helpful, even though it seems strange that it would be, but it is. Okay. I think we've run out of time for our myths versus facts. We did prepare, we will have some time right at the end if there's any more questions that come up though, right? So I can pass it back over to you, Dr. Khara, for some additional considerations.
Sure. Yeah, I'm just being distracted by some really good questions.
Oh, we do them now?
Well, I'm just going to comment on the one that's just caught my eye. I have a
Okay.
client struggling with nausea at 4 Champix doses. Soda crackers are also really helpful to control the nausea. Yeah, great. They may well be. Full stomach, full glass of water, those things definitely mitigate the nausea. And whether it's soda crackers or whatever else that seems to be the trick, yeah, encouraging people to not take them on an empty stomach is good. Okay, so and we're going to have a bit more time for discussion at the end. So let me just get into some other things that we can think about when we are choosing what treatment to use. So whilst you try and absorb this really complex looking slide, which is actually quite brilliant, but I'm not going to go into it. You can look at it in your own time, but it describes some of the very many things that can happen when we're choosing smoking cessation medications for our patients. But I would like to editorialize this by saying that I think of a few main things for patients when we're choosing. The first is, what does the patient want? Because you're going to get the most buy-in if the patient who comes with a preconceived idea, whether that's based on a family member's experience or their own previous experience or whatever, if you go along with that option, assuming that there is no real strong reason to not use that option, that's often the most important consideration when I'm helping somebody choose. So somebody who says, my uncle used Champix, it worked brilliantly, I really want Champix. Well, let's do Champix unless there's a specific reason to not do it. If he's in renal failure and he's going for dialysis every 2 days, well, we might not use the Champix in that context, though we still could with a change in dose. So personal preference, past history with a product should really be strong definers of where we go. Zyban is a good option. I, by and large, don't use Zyban anymore because my thinking is that we have an oral medication that is demonstrated to be more efficacious, Varenicline. And Varenicline appears to have less day-to-day side effects than Zyban, as far as I can see, with the anxiety and the sleep disturbance that comes with bupropion. So I would never use Zyban as a first line unless the patient says, I used Zyban 10 years ago and it worked really well for me and I'd like to use it again. Well, that's not the time for me to say, no, I think you should use Varenicline because it's more efficacious. So patient preference. The other thing to remember is that reduce to quit, which I think is on the next slide actually, is something that we should be really thinking about as an approach for our patients. Many patients have delayed entering smoking cessation, sometimes for years or sometimes for decades, because they were under the preconceived idea that when you put the first patch on, you have to quit smoking that day forever, which is such a shame when we know that there is now this approach where patients can put their patches on or start their Champix and just kind of see how it goes, and which will inevitably happen. And as reduction happens, confidence grows, maybe rapport with the care provider increases, discussions around next steps start to happen. So remember, reduce to quit is a legitimate way to approach cessation. And in fact, in the context of NRT, has been demonstrated to be about as efficacious as abrupt cessation. And it's been a big obstacle for many patients, and many patients, I'm sure you've had this experience, Sophia, who will say, I wish I'd known I could have done this before. I wouldn't have delayed it for all this time. Also thinking about the kind of follow-up we're going to do. So I'm very fortunate in the way that Sophia and the folks at CAMH are, and that I work in a specialist cessation service where I can see people every few weeks to follow up and see how things are going. But I would encourage you to try and do that, so you can tweak and also follow for any adverse events. What else are we going to talk about before we hand over to questions? How long have we got left, Natalie?
When you're ready to move to case study, I think that would be.
Okay, let's do that, because we can talk about lots of the things that are on the other slides in the case study. So let's talk about Zoe.
Okay, I can read it out for everybody, and then please put your comments in the comment section, and we can talk about this case study and then also answer other questions as well. So Zoe is a 42-year-old woman with bipolar disorder and COPD. She came to Intrepid Lab with the goal of quitting smoking because she's been noticing it's been making her COPD worse. She shares with the physician that she's tried quitting in the past using the patch, but she was allergic. Unfortunately, she said her GP won't prescribe Varenicline or Bupropion to her because she has bipolar disorder. Are there any misconceptions that you should try to address? If so, how? What do you need to consider when choosing which quit aids to recommend to Zoe? What questions should you ask her? What quit aids would you recommend or prescribe Zoe, and at what doses? So I'll give you all some time to write some comments and some responses to the case study in the chat, and then we can talk about it together.
Whilst people are thinking, Sophia, can I just answer another question, which is kind of partly
Yes.
to this? The question about why I'm sorry, I've forgotten the name of the person who asked the question. I can't find it anymore. Why her patients come back and say that the Champix is not successful the second time round when it appears to have been successful the first time round? Is there an explanation for that? I've heard this a few times. I'm not sure there is an explanation for it. And again, I'm not sure it's necessarily a thing. I mean, is it more about just the patient being in a different place at a different time? Not every quit attempt is the same. I'm not sure there is a mechanistic explanation for it. I don't think we become tolerant to Varenicline. I've had lots of patients who've used Champix a second time, months or years later, when it does work very well. So just an aside.
Are you seeing any comments for the case study?
Ask more questions surrounding allergic reaction to patch firstly.
Okay.
See that in the comments? That sounds reasonable to me.
Right, because for a lot of people, so that's a good one in terms of, things to consider, is asking Zoe more about that allergic reaction. So we would want to know that. Is it a true allergic reaction? Because we know that nicotine is irritating. So most people, for the most part, you probably will get that itchy, irritated feeling when you wear the patch. So finding out, was it just that, or was it an actual true allergy, is an important first thing to find out from Zoe.
And there's a comment about bipolar being stable, which again makes sense to me. There can be a concern around using bupropion and stimulating mania in somebody with a bipolar disorder. So much more history about her bipolar disorder would be very useful. What quit aid are you recommending here, Sophia? If she's a blank piece of paper and says to you that she's open to trying anything, and let's say that her allergy to patch turns out to not be very much, what things are on your list of options here?
I'm most comfortable with trying the NRT first. I know that we've gotten a lot of from the this might sound counterintuitive, but yeah, if she's been stable for 6 months, if I would go either with Champix or the NRT. For the NRT, I think it's worth revisiting, especially if it's not a true allergy, we can problem solve around it and get the NRT right, since she's already tried it. So if she was open to that, I think it would be fair to try that first. If she has been stable, like we said, I think even with Champix, we still want to. I think it's still recommended to be stable for 6 months before trying it. So we would, consider that first and then potentially try Champix.
Yeah, I would agree with that. I mean, as much as the Eagle study tells us that in a stable psychiatric population, there is no increase in adverse effects when compared to placebo, we very rarely see stable psychiatric populations in reality, right? Most of the patients that we see with a history of mental illness are difficult to define as truly stable. So though I think we can use Varenicline if we decide she is stable, it always seems to be logical to make sure that NRT has been adequately tried and is an option. So I would agree with that. I always like to go with NRT first. Wondering what everybody else is saying out there. I like the comment about clients reacting with one brand of patch and not the other. And that's actually true, that it seems to be a reaction to the adhesive. It's not a reaction to nicotine, it's a reaction to the adhesive. And actually that can be quite reassuring for patients when they hear that it's not some kind of nicotine thing, because there's so much fear around nicotine, and a bit of a red rash just kind of reinforces that pre-existing fear. It's the adhesive that causes it, and just knowing that can be enough. But switching to the other brand may well lead to there being no reaction.
Okay.
Okay,
So
we're gonna skip on.
Yeah, we'll skip on to wrap it up. So we can skip through the other case study. I don't have control anymore though, so I can't.
Oh, I think I do. Okay. So here's the answers in case anybody wanted to see these.
It was just a couple comments. It wasn't all the answers, but
yeah. Yeah, and there is a comment about how much does she smoke per day? Maybe short-acting NRT. Again, legitimate. Maybe she wants to use the gum. Maybe she's not a heavy tobacco consumer. We didn't actually have that in the stated history. Natalie, do you want to take control and stop me and Sophia talking till 4 o'clock this afternoon?
Sounds good. Yeah, we have a couple. We'll skip over William. People can refer to this one after. And we talked about this at the beginning, so maybe we'll skip to questions. And we have a couple minutes left for questions if anything was unanswered. So feel free to pop your questions in the chat.
Whilst those are coming up, why is the patch recommended for above the waist? That was how the trials were done, and it was based on above the waist being less hairy than below the waist. But actually, the patch can go anywhere where it'll stick.
Any thoughts on Zonic?
Let's not use our remaining time on Zonic, which is an oral nicotine pouch about which we could talk at length, about which not a lot is really known in terms of its potential efficacy, but of course it's being marketed as an alternative to NRT. Laurie's question is maybe a really good one to just touch. Any advice for vaping cessation? I know that this is a thought in everybody's minds in this space. Just to very quickly sum up the where we're at with vaping cessation, essentially we are in an evidence vacuum for vaping cessation, but increasingly what people are doing is borrowing from what we know about tobacco, using the idea that nicotine addiction is nicotine addiction is nicotine addiction, and using NRT and the same kinds of behavioral counseling amongst youth. I certainly use a lot of short-acting NRT for vaping cessation, with mixed results. I think the results are not a reflection of the treatments, but are more a consequence of the youth that I see often being ambivalent about cessation. If you're dragged into the clinic by a parent who wants something to be done, and the NRT doesn't work, well, it's not the NRT that's failing, it's maybe readiness to make change that's failing. So.
Yep, and I'll just add that we do have, I think, 3 to 4 upcoming webinars on vaping, so please keep an eye out for that, and we'll talk in more depth about it then.
Mm-hmm. And there's a teach course on vaping as well. I just took it. It was really, really, really helpful.
And one more quick question on that subject. How do you address a client wanting to vape as a way to quit? And we'll just refer you to the big studies now that suggest that vaping is a legitimate treatment, it may be as efficacious as NRT. Some big problems around what advice we give our patients, which device, what dose, for a largely unregulated product. Some real big questions that maybe will be dealt with in these future webinars, but clearly it's a question. It's a good question.
For sure. Now, I know we have a lot of questions in the chat. I think we covered most of them, but if there's any unanswered questions, are you two okay if people reach out to you via email here?
Yes.
Awesome. So yeah, feel free to take note of their emails. We'll also send this along with the slides. But thank you so much, Dr. Khara and Sophia, for such a lovely presentation today. I know there's a lot of content to get through, and you did such a good job, and I know everyone learned a lot. So thank you so much. Yeah, and just before we head out, I'll just do a few reminders. So want to remind everyone that this webinar has been recorded, and I'll be distributing a link to it as well as a copy of the slides, so you can all refer back to or share with any colleagues afterwards. Along with this, I'll also share a link to the evaluation and post-learning assessment that must be completed by next Wednesday if you're interested in receiving a letter of completion. And just a heads up about our next Teach Educational rounds with actually Dr. Lori Zawatello and Dr. Selby on May 31st, talking about the health effects of e-cigarette use. So keep an eye out for registration opening soon for that. And if you happen to miss a portion of today's webinar and want to view it again, or miss another Teach webinar and want to see it, an archive list can be found on our website as per usual. For now, thank you all so much for joining today and for your participation. We hope you all have a lovely rest of your day. Thanks, everyone. Bye.